Hi everyone. Thank you so much for those of you who are joining live and for those of you who watch later on YouTube. Um, we've covered quite a few blood gases and different clinical scenarios from towards the end of last year. And this is one of the last ones now that we'll do on the understanding the arterial blood gas. But I hope those who have followed those lectures will at least understand the importance of it as a tool in emergency medicine and how to at least be able to have a basic understanding of how it functions and how you can use it and how to correct abnormalities based on it. So today we're going to talk about mixed respiratory and metabolic acidosis, which is not something that you'll come across very often, but it is something that you will come across, and you need to know how to approach it because it will be, more important is the differential diagnosis when you are faced with one of these, because generally you find one or the other. You get a respiratory acidosis, and then your metabolic side sort of becomes alkalotic to counteract that, and vice versa. We have metabolic acidosis, your respiratory side tries to compensate by retaining carbon dioxide, so on and so forth. So a mixed respiratory and metabolic acidosis is not as common, but it does happen. So an important thing to understand. So let's just move on to the next part of it. So here we have a patient scenario. So we have a 45-year-old female patient. So presenting to the emergency department with severe diarrhea for 3 days, shortness of breath. She is lethargic and unable to provide a detailed history. So she's a known type 2 diabetic and with shortness of breath and obesity as well, currently on metformin, antihypertensives as well. So that there, although no smoking and alcohol history. So already your mind may be going towards an acidosis because it's a type 2 patient. She's been having diarrhea, possibly abdominal pain, shortness of breath. Maybe it could be a Kussmaul type breathing. You may be thinking this could be a DKA. So, but in any case, a patient who is lethargic, unable to provide you with a good history, should already be somebody who's, who warrants an ABG. And, with severe diarrhea for 3 days, of course, you always worry about electrolyte abnormalities as well. So if your blood gas has the capability to give you electrolytes, then of course that helps a lot. So I know, like with us in the public sector in South Africa, recently due to cutbacks, a lot of the machines now no longer give you electrolytes because those canisters cost a lot more. So they just give us very basic information. But if you're still working in an area that gives you electrolytes, it's quite a handy thing to have. And it's something I know that we miss at the moment. So what's our examination findings? We have quite a low BP. The patient is obviously going into shock, hypovolemic shock with a high heart rate, low systolic. If you work out your shock index, it will probably show you a high probability of shock, a respiratory rate that's quite high. Sets are a bit low on room A, but not drastic, and her temperature is still relatively okay, but maybe tending towards a bit high. And the general appearance is somebody who's lethargic with Kussmaul breathing, and the chest examination has clear lung field. So even before get all your results back, you might already be thinking of a DKA and possible electrolyte abnormalities. There may, of course, be a renal impairment as well because the patient is on metformin. So there's quite a few things that may be going on here. But let's have a look at the ABG. So just put it here in British units because I know a couple of people are saying that there's what I've been teaching you guys doesn't match up with what they get. So in US and those countries that follow more the US teaching, and even though so a couple of the students from India and Mauritius and that, They do use slightly different units, but it's just to give you an idea, more or less, you know. So in this case, we have a pH of 7.15, which is a relatively severe acidosis. Our carbon dioxide now is trending upwards, so that's respiratory acidosis that the patient had. So the patient is retaining carbon dioxide, all right, and is in a bit of respiratory failure. And we talked about respiratory acidosis before, and we had talked about type 1 and type 2 respiratory failure. And considering the patient has mild hypoxemia, you'd consider this to be a type 2, respiratory failure. And then your bicarb is only 10. So the patient's also got a metabolic acidosis. So as I was saying, it's not a common thing to see. Normally, if you see your PCO2 increasing, you see your bicarb increasing as well. And if you see your bicarb decreasing, you would see your PCO2 also decreasing. But this is not what's happening here. In this case, both of them are contributing to that. Now, that's because you've got a multifactorial disease over here. Could you have an infection overlying a DKA? Could you have a renal impairment, overlying another lower respiratory tract infection? There's quite a few things that are going on. So the question is, what do you do now when you're faced with it? So the important thing initially in the emergency department is to at least consider the differentials, to at least consider what could be the things. So what are the main causes of respiratory acidosis? We had discussed this before. So it's hypoventilation, obstructive lung disease, sedative overdose, infection, pneumonias, things like that. These are all things that can lead to respiratory acidosis. And metabolic acidosis could be due to diabetic ketoacidosis, lactic acidosis, which can be due to sepsis, hypoperfusion, renal failure, or severe diarrhea in this case, which also causes loss of bicarbonate. So you've got all of these factors mixing together, leading to this picture. Now, the most important thing on this patient that you can see now, if you look at her ABG, yes, her pH is low. Her PaCO2 is a bit high. She's not at a level where you need to intubate. PaO2 is not so low that you need to rush. You can probably give her oxygen via mask or nasal prongs to probably improve. You're not going to start suddenly giving her bicarb and things like that. The most important thing for her at the moment is fluids. This is what you need to get into this patient because let's say we find that she's got a blood glucose of 30 at this point now. There's a very high likelihood that she could be in decay. Now, we don't talk about the blood glucose in this particular presentation, but I'm just giving you an example. Due to the diarrhea, she could just have straight hypovolemic shock, or it could be due to DKA and the diarrhea, it could be due to renal. There's so many things that could be causing it. But at the moment, what we have here is that we have a patient who requires a lot of fluids and who requires respiratory support in the form of oxygen. And I mean, you're not going to try and get up to 100%. Most of our patients, once you're between 94 and 98, that should be fine. Like I say, your temperature is trending a bit high, but it's not terribly high. This is one of those where you would feel the patient, examine the patient, consider that there may be signs of infection. So you would take your white cell counts, your CRPs, your ESRs, your procalcitonins if you have access to it. And you would have a look at that and see, do you need to start antibiotics? Is there an element of sepsis as well? So these are the types of things that you are trying to get to the bottom of and what you're trying to sort out. So the main thing in the emergency department at first, while you're waiting for all of these things to come, is that you try and get fluids into this patient and you try and get oxygen into this patient. Those are the main things. So once you get oxygen in, you blow carbon dioxide out generally. And as you improve your circulation, you tend to also move lactate out of the system. You tend to improve perfusion of the peripheral tissues and things like that. So these are the things that you need to try and do. This is the type of patient who warrants immediate catheterization. You want to see how they are responding to your fluids as well. Are they producing sufficient urine, insufficient urine. The patient's diabetic, hypertensive. There could be a nephropathy going on with renal impairment, so there's a lot of things that you need to look at just at the start. And then, of course, you have combination triggers for mixed acidosis, which is cardiac arrest, severe sepsis with respiratory failure. And one of the ones that's often overlooked is aspirin overdose. So if you go back to our series on toxicology, I think it's number 3 or number 4 in one of those. No, I think it's on the third lecture. I've got a little section where we talk about salicylate toxicity and aspirin overdose. And aspirin is one of those drugs that can be overdosed acutely and give you acute symptoms, or you can have chronic overdose. So your patient has chronically been taking aspirin and eventually develops toxicity. And one of the things that they do develop, although more commonly in the acute setting, is this mixed respiratory and metabolic acidosis. And it's one of the findings in salicylate toxicity. Patients also develop tinnitus, they're very lethargic. There's quite a few things that go on. They become pyrexia, and they become extremely hypokalemic as well. And they can develop coagulation or coalescence of the pills within the stomach, causing acute blockages of the stomach. So it's quite a few things that you can look at, as far as salicylate toxicity goes. And it's not an uncommon overdose. Generally, aspirin is viewed as a safe drug. It's the same thing with paracetamols. So because it's viewed as a safe, I say safe in inverted commas, uh, many patients who are attempting parasuicide or who just want to show that they are not okay and that they need help may often turn to paracetamol and disprins, aspirins, whatever it may be. And you need to know the different preparations that are available in your area, different trade names, things like that. Because the feeling is that, okay, this is a safe drug. It's over the counter. I just walked into my store and I bought 5 packs and nobody said anything. So if I take 40 of these tablets, nothing's going to happen to me. And but they'll know that I'm unhappy. Unfortunately, for some patients, that's the only way of reaching out. Psychologically, that's the only way they feel that they can get across the message that they are not happy. But not realizing that they're actually doing significant damage to themselves. In South Africa, I know paracetamol is much more common in terms of these types of overdoses. And in fact, patients get quite a shock when they realize that they have actually done some harm and done serious harm to themselves. And but I know overseas, aspirins, disprins, these are more commonly dispensed, over the counter. So it just depends on your geographically location. You may see this more commonly. So it's just something to remember, if you do ever come across a patient with this. So how do these patients present? So as with most patients with acid-base disorders, there tends to be some, altered mental status, tends to be changes in breathing patterns because of trying to either get rid of or keep carbon dioxide. There can be urinary symptoms as well. But generally, you'll find your patients will have rapid, deep breathing, because they're trying to get rid of the carbon dioxide. They tend to be lethargic, confused. They do become hypotensive as well. This has to do also with peripheral vasodilation in these patients. And in severe cases, they can go into, alternate mental status, of course, but cyanotic and multiple organ failure and things like that. So it's our job to make sure that they don't get to that stage. So how do we do that? So the initial management, like anything in the emergency department, is the ABCs or CABs, however you want to look at it. So you make sure in this case, the circulatory support is good. So you're going to give IV fluids to treat the dehydration, hypovolemia. You are going to try and make sure that they're getting enough oxygen in there. And you may decide on invasive ventilation if it's necessary. Vasopressors are advocated for in this particular type of hypotension if it's purely due to the due to the acid-base disorder, due to the respiratory and metabolic acidosis, simply because the presses work very well on the peripheral vasodilation that is often leading to the hypotension. However, not everybody has access to presses. Pseudoephedrine and what's the other one? Phenylephrine and all of that. So most of us, I know in the public health sector in South Africa, we would only have access to adrenaline, but it's a good enough start. And then once your patient is in an ICU setting where your presses are more readily available, that's where they normally start them. However, in quite a few of the emergency departments, now they've started to use presses on a more regular basis. And to be dead honest, if you have a department that's well run and has sufficient experienced people, you can easily use presses there. However, they do require more intensive monitoring. So it's not just from a medical side, from a nursing side as well, there has to be quite a bit of commitment to monitoring these patients. Okay. So, like I say, in the specific management is you try and treat the underlying cause. So if the patient has a high blood glucose level, you would start treating them as per your DKA protocol. If you find out the patient has sepsis, then of course you would treat them with antibiotics. If a patient has an acute respiratory problem, you would give them bronchodilators or reverse sedatives that may have been taken. So there's quite a few things. Now, in our particular patient, she's diarrhea. She's got severe diarrhea. She's diabetic, hypertensive, and hypotensive in this case. So we would give her fluids. We would give her oxygen. And should she be showing signs of a diabetic ketoacidosis, then we would also, of course, try and correct that. So that's how we would look at this patient and how we would treat this patient. So that's it's not a very long session today, and thank you for those of you who agreed to let me do it a day late. And hopefully we'll have another session next week where we'll discuss. I'm hoping to discuss septic shock with you guys and have a few discussions on shock and things like that. I've noticed it's something, so especially now in the new year, with a lot of you starting off as interns and new community service doctors with newer responsibilities that you haven't had before. Shock is one of the most common presenting symptoms in any emergency situation. Even if you're working in wards or you're working in outpatients clinics and things like that, shock is an important thing to recognize. So hopefully we'll talk about that. But yes, basically, as he's drawn it out here, if you really want to get into the nitty-gritty of blood gas, you can delve very deep into it. What I've given you guys over I think it's now 4 or 5 lectures, is a very, I would say, not surface level understanding, but just below the surface. But we've only scratched the surface. You can go in very deep into this topic, and you can learn a lot. And there's obviously various complicated interplays that take place between all of these things. And should you end up doing ICU medicine, internal medicine, anesthesia, in so many of these cases, emergency medicine as well, you need to know your blood gases extremely well. So, but as a junior doctor, if you understood what I've taught you over these few sessions, you won't get into trouble, and you will know at least how to manage your patient and get your patient out of trouble and stabilize your patient, and then be able to look at differentials. Actually, that's the nitty-gritty of it comes about. The interplay shows the different differentials and helps you go down an algorithm to get to a point where you can say, no, this is the more likely differential, or that's the more likely differential. So hopefully you guys enjoy that. And yeah, hopefully we'll have another session next week. Thank you very much. Keep well. I do appreciate all of you who have listened. Thanks. Bye.